Thank you very much for the opportunity to speak today. So I'm here to present the results of a trial that formed my PhD programme and also the body of my academic research so far. Now I have two hats. My first hat is that as a clinical cardiologist, and my day job is to take patients who have angina and disease in their arteries, so they have narrowings in their arteries and chest pain that has brought them to our clinics, or to take patients who are having heart attacks, narrowings in their arteries that have now caused them to present with an acute blockage in the artery. And in those patients, I put stents in. Now stents, if those of you who don't know about them, are wire mesh cages that we put into arteries to open up blockages. Now that's my normal day job, but actually half of my work is also to do academic clinical research. And it's important to remember my two hats as I talk to you about the trial that I performed, because actually they brought my two worlds together and actually conflicted in the results. So this is an example of a coronary artery. This is the right coronary artery, and it shows a narrowing right there in the middle, a pinched area within the artery. And this is an angiogram from a patient who presented to one of our clinics with what we call stable angina. So these are patients who have chest pain when they walk, when they're going upstairs, when they're walking up an incline, and when they stop and rest, that pain goes away. We call it stable because their risk of having heart attacks or potentially having sudden cardiac death or any other problems is very small. But the treatment for most of these patients at the moment is to open up that artery with a stent. And the question we had was, why do we stent these patients? Now, it's important to remember that 500,000 procedures in patients like this are performed worldwide. These are not patients having heart attacks, they're patients with stable disease. And there are many treatment goals in these patients. The first was actually always relief of their symptoms, making these people feel better and improving their quality of life. But over time, as stenting doctors, we hoped we could do more. We could potentially prevent death in these patients, or prevent other problems such as heart attacks or heart failure. And for many years we were stenting these blockages because we thought if you didn't stent a patient with stable disease, they would become a patient with unstable disease, and so we needed to catch these narrowings early. In fact, the data has shown us time and time again that the best thing for these patients is in fact tablet therapy. If we give these patients statins, as we've heard, and other medical therapy, we can prevent their stable disease from becoming unstable. And this trial produced a massive shockwave in the stenting community, because it showed, on a background of much data that had gone before it, that actually stenting in these patients did not help reducing their death rates or their heart attack rates. But what we believed over time was, while we couldn't prevent death necessarily with a stent, or prevent heart attack or heart failure, for that we needed to give these people the right drugs, what we might do is still improve their symptoms and their quality of life. And there's been a number of trials looking at this. But our question, and my question for my PhD, was how do we really test this adequately in a clinical trial? The trials that had gone before had shown very conflicting data. Some had shown that if we opened up these arteries with a stent, the patients felt much better. They reported that their angina had gone away, while others said the benefits were a bit more modest. And actually what we'd always seen is that over time, patients will initially tell you they feel better. The pain has gone away, doctor, I can now walk without getting that chest pain. But over time, for many of these patients, their angina came back. And the question was, why is that? We felt it might be because the trials that had gone before had been unblinded. And by that I mean that the two groups both knew exactly what treatment they'd had done. One group would have a stent, one group would have no stent. And of course, if you have a stent, you may potentially feel better because of the effect of that stent, but also because you feel the doctor's opened up that narrowing that you're worried about. And the group that don't get the stent, of course, worry that they've got a narrowing in their artery that hasn't been fixed, and they may re-present to doctors with chest pain again. So we felt that for the first time, we should perform a placebo-controlled trial in this area, and this had never been done before. We wanted to perform this trial because we felt that the true benefit of stenting was unknown. We didn't know what the true physical effect of what we did was, and how much of the component might be placebo. We also know that stenting isn't without risk. There are some short and long-term risks. So you may not want to have a stent in this condition if you find that the risks outweigh the benefits. Tablet therapy is certainly an alternative, and for some of our patients that's all they would want or all they would need, and we wanted to test this in a trial. And finally, we know that our patients have different responses to their stents. Some people have a stent in that artery and feel so much better. The others come back to us in clinic saying they feel exactly the same. And I wanted to work out why there was a difference in the way they reacted to their stent. We'd seen other trials, and I won't go into the details of them, but trials of therapies in which the original trials that were unblinded showed a great effect size, a very large effect from the therapy, and the moment that therapy was tested against placebo, there was suddenly a much smaller true effect size. So we felt that for a subjective endpoint such as symptom relief, quality of life improvement, how far we can exercise, we needed a placebo-controlled trial. And this formed the basis of designing the ORBITA trial, which was designed here at Imperial. We took patients with stable angina and we wanted to answer a series of questions. The question was, does angioplasty, does stenting improve exercise capacity? Does angioplasty improve symptoms and quality of life? Can we predict which patients would do the best from their stents? And is there a placebo effect to what we do? And finally, is tablet therapy truly a viable alternative? Or, for many patients, would those tablets have too many side effects and be too cumbersome for them to take in the long term? So whatever the results, they'd rather have an upfront procedure and just have that narrowing fixed. This is what we did. We took a series of patients and wanted to answer one principal hypothesis, and this was very importantly for symptom relief. We weren't looking at whether we could reduce heart attacks or death. We were primarily just looking at whether patients would feel better if they had a stent. And our hypothesis was that angioplasty or stenting would improve exercise time more than a placebo procedure. We took 200 patients and we performed a sample size calculation, assuming that the exercise time would improve by 30 seconds more in the angioplasty arm than the placebo arm. We recruited patients with chest pain or breathlessness on exertion, the kind of patients that come to our clinic saying they have symptoms that we would diagnose as stable angina, so these were not heart attack patients. These patients had severe disease on a coronary angiogram and the kind of disease that we would normally consider as suitable for stenting and the kind of people I've been stenting for years. They came into the trial and they initially had an enrollment assessment where we basically assessed their symptoms. They've answered a series of questionnaires and graded how bad their angina was or how limited they were by their narrowing within their artery. They then went into a very intensive medical optimization phase, and this was different to other trials because the guidelines currently say that when someone comes to clinic with stable angina, they should have tablets started first, and if those tablets fail or if they can't tolerate those tablets, we should consider a stent. The truth is that's hard to achieve in the worldwide clinical practice because of course that involves seeing patients on multiple occasions and trying to get their tablet therapy improved, and usually patients and their doctors skip that step and go straight for the stent. But in this trial it was important to us to test stenting on the basis of the guidelines that we have out there. After they'd had their medical therapy up titrated, they then came in and had their questionnaires repeated, but also an exercise treadmill and something called a stress echo, in which we scan the heart and we have a look at how much that narrowing is affecting the blood supply to the heart. They then came in for a crucial part of the trial, which was the blinded procedure. These patients were wearing headphones and listening to music. They had an angiogram procedure, so we made a nick in the artery in the groin or in the wrist. They had tubes put up into the arteries, and they had a series of measurements to have a look at the blood supply to their heart, and then they were sedated. They were put to sleep till they had a deep level of sedation and were essentially fast asleep but not needing any anaesthetic support. And at that point we pressed a button. Half the patients in the trial had a stent, half the patients had nothing more done, and they all knew that this is what may happen. They may have a procedure in which nothing more than a placebo procedure was performed. They then came out of the cath lab and were woken up outside, and out there the team had no idea what they'd had done. They entered a 6-week blinded phase where again both groups had no idea whether or not they'd had the stent, and then they came back and had all of their original baseline measurements repeated to see whether they had improved. And of course, all of this was blinded, with them not knowing what they'd had done and none of the researchers in the team outside having any idea what had happened. Blinding was very important to this trial because this is what made ORBITA unique compared to all of the trials that had gone before. So those patients were listening to music, they were sedated, and after we pressed the button on the computer, half of them had a stent, and the patients who didn't have a stent were on the table asleep for at least 15 minutes before they were taken outside. They all had the same medications, the same post-procedural instructions, and the same discharge letter, which actually told their GP they may or may not have had a stent. You won't know for 6 weeks, it's all a secret. And outside, the clinical team had no idea what these patients had done. And they got very used to being able to manage patients all as if they'd had a stent, but not knowing what they'd had done. And this really was very unique. Now, the primary endpoint of our trial, as you might remember, was our hypothesis was that exercise time would improve more in the stenting group than the placebo group. So the primary endpoint was the difference in the exercise time on a treadmill between the two groups, the placebo and the angioplasty group. The endpoints were all assessed by blinded researchers, and they were all analysed by blinded researchers, so no one knew what the treatment allocation was. 230 patients were enrolled in 5 centres in the UK, and Imperial was the primary site. Those patients entered a medical optimisation phase, and 30 patients exited. 17 of those exited because they had felt that their symptoms had improved, and they no longer wanted to have a stent. They were quite happy as they were, and they dropped out of the trial. 200 patients were randomised, which was what we aimed for, around half to angioplasty and half to the placebo procedure, and those are the follow-up numbers. Now, in a randomised trial, the most important things that people look at are whether the two groups were similar, and when that button was pressed and they were randomised, whether we got a similar allocation of patients with similar risk factors in each one. And in fact, the groups were very well matched. They had very similar levels of diabetes, high blood pressure, high cholesterol. They had overall very good heart function, and the groups were very similar. They had all presented with an angina duration of more than 8 months, and predominantly they were symptomatic patients. Now, in the medical therapy phase, when we first started the trial and enrolled the patients, we found that the majority of patients were on 0 or 1 anti-anginal. Now, the guidelines would say you shouldn't stent a patient until they're on at least 2 anti-anginals. But these patients had all been referred for a stent. So in actual fact, many of the people we stent in our cath labs will not have had as much medication as the guidelines would suggest. By the time they'd finished the medical optimisation phase, the average number of anti-anginal medications, so those medications that improve the blood supply to the heart or make chest pain better, was around 3 per patient, which is a lot more than normal clinical practice. And this stayed the same as at follow-up. Now, the procedure itself worked in the stenting arm. We did measurements to look at whether the blood flow to the heart improved, and in fact, the stenting worked. The blood flow to the heart certainly improved in the stenting patients. But every trial lives or dies by its primary endpoint, and that's what in the end, the publication is based on your primary endpoint, because of course that's what you most wanted to test at the outset of the trial. Now, in terms of the primary endpoint, the change in exercise time between the two groups, we saw that there was an improvement in exercise time in the stenting arm, and it was 28.4 seconds. However, for the first time ever, we had this group that hadn't existed in previous trials, a placebo group. And here there was some improvement, 11.8 seconds. And that meant for the primary endpoint of the difference between the two arms, the effect that we'd expected to see was much smaller and was not statistically significant. And this was kind of a revelation to us all. We did find other aspects of the trial that were interesting. We found again that on the assessment of the stress echo, the scanning of the heart to look at the blood supply to the heart, stenting improved the blood supply to the heart significantly more than the placebo group. But this didn't translate to them feeling that much better. Both groups improved in terms of their angina, and if we look at these green boxes, that's the number of patients who said that they were free of angina at the end of the trial. The stenting arm patients said they were a little bit more free of angina than the placebo arm, but actually the statistical difference on the first analysis didn't show a significant difference. Now, I presented the data at the biggest interventional cardiology conference in the world, where it's in America, where they make a lot of money out of stents, on a panel of stenting doctors, and all of a sudden, my two hats collided. I was a clinical researcher who usually puts in stents, now presenting some pretty negative data for stents in an audience who like to put stents in. It was a hard time for me, but the paper was published in The Lancet. In fact, we made the front page of The Lancet at the same time, and there was a simultaneous publication. And obviously, this was an academic success, but we hadn't really anticipated, perhaps as a bunch of researchers from the UK, what a trial may mean outside of the UK. So in the UK, our system is based on very much testing what we do, and I'm proud of that. We're prepared sometimes to just hold our hands up and say, the effect of what we do may not be quite as we thought. Let's have a think about that a bit more. It doesn't necessarily change everything we do immediately, but we're prepared to accept that. Of course, I think as a bunch of researchers, we had perhaps been naive to the fact that stents are big business. And there are a whole load of companies out there who really care if patients are being stented. For us in the UK, this stable angina population makes up only about 1/3 of what we do. However, in the US and in other centres, you may think if you've got an incentive to put a stent in, you may stent some more patients who perhaps we in the UK wouldn't stent so commonly. So all of a sudden, we were all over the news and everyone wanted to talk about this trial. And some of our patients became famous as we were interviewed all over the place, discussing the concept of stenting. Unfortunately, at the same time as my paper being published, an editorial was published which came out simultaneously and called for angioplasty and stable angina to be revisited and perhaps to be downgraded as an option for patients. And again, I have to hold my hands up and say we hadn't expected that. We perhaps hadn't expected that in the US there is a brigade of doctors and scientists who believe in less is more. There has been perhaps an over-proceduralization to what they do and a sense that perhaps what cardiologists do is financially driven. So these people came out straight away to say this is a fantastic trial and stents need to be downgraded. I didn't agree with their results, but as a result of what they did, all of a sudden I was in the New York Times, in the Wall Street Journal, in Time magazine, and all of a sudden those two hats were colliding again. I was a scientist who'd found a result I hadn't expected, but in fact 50% of what I do is to do procedures a little bit like this. And so all of a sudden there was lay media and people out there perhaps over-interpreting or even interpreting our results incorrectly, and that was tricky. So all of a sudden the share prices dropped. The stent companies suddenly had a 2 to 3% drop in their share price, and my husband, who's in finance, sent me a Bloomberg report that said Dr. Al-Lamee has published a small trial in the UK that has affected the Minnesota stent companies. Let's be honest, I had no idea that was about to happen. So it was, this was what happens sometimes when you produce science. All of a sudden, people outside of your world are interested in your world and interpret your results in a way you might not want them to. Everyone will be happy to know the stent companies have recovered and they have gone out there with a backlash against our trial and they're feeling a lot better. So over time, things have improved. We've gone from everyone hating our trial to it being a Marmite trial where some people hate it, some people love it, some people are starting to actually just have a think about it a little bit more. And in fact, we made the best trial of 2017 in cardiology. There have been already, since the paper came out in November, multiple editorials, some saying this was a great trial, some saying they were a bad trial, all writing about ORBITA. But actually, my conclusion from ORBITA is that ORBITA left us with many, many more questions than answers, as is always the way with stenting, with science. We do not understand why angioplasty did not improve exercise capacity as much as we'd expected. We don't understand why the symptoms didn't improve as much as we'd expected. And in fact, I thought this trial would be a slam dunk for a procedure that we do all the time. It didn't make sense to me that the blood supply to the heart had improved, but this hadn't correlated to symptomatic or exercise time benefit as much as we'd expected. And we did have the question, perhaps the baseline level of disease might influence the results. And those people who have more disease or a lower blood supply to the heart may stand to gain more from having it opened up with a stent. And so we went to analyse some of that a little bit further. And I have now published a further paper which was published in Circulation and which I presented in May, where we looked at secondary analyses that had not been pre-specified. So of course we were able to analyse more and not live or die just by a primary endpoint. And interestingly, what we found was while the doctors reported very little difference in terms of angina between the two groups of patients, in fact, for the patient questionnaires, those patients who had a stent were more likely to say they were free of angina. They were not more likely to say that their angina had improved a little, but they were more likely to say it's gone. And perhaps that's because it's easier for us to say the pain I had 6 weeks ago is now gone, versus those people who just maybe have a little bit of improvement or a little bit of deterioration, and those grades of change are harder for them to look at. And initially in the primary paper we were looking at grades of change, and perhaps we hadn't been able to see more binary changes, I have pain or I don't. And in fact what we found was 1 in 5 more patients in the stenting group were free of angina than those who'd had the placebo. What we also found was that when we looked at disease severity based on the baseline level of the blood supply to their heart, the tighter the narrowing and the more it had an impact on reduction to the blood supply to the heart, the more stenting improved the blood supply to the heart when we put that stent in. So that was very interesting, and it was a placebo-controlled improvement. When we took away the placebo effect, the stenting worked in improving the blood supply to the heart. However, what we didn't find was that those tighter narrowings had any more to improve on exercise capacity than those ones who didn't. And this had been one of our hypotheses, that we might see that the people who have tighter narrowings, once they have a stent, are more likely to benefit from exercise on their exercise treadmill. And the question was why? And now I'm starting to think much more about the academics of what we do. And actually, if we look at the therapeutic effect or the treatment effect of anything we do on a subjective endpoint, so that's not death or heart attacks, it's on something that's more subjective like chest pain or quality of life. This blue box can be represented as the overall treatment effect. And for any treatment like this, there will be some placebo effect, and we have to recognise that that exists in both tablets and in surgery or interventional procedures, and some physical true effect of the procedure or the tablet. And for simplicity, I've said it's 50-50, but of course it will be different for different therapies. Now overall, for a patient, what they care about is the overall effect. And that may be made bigger and greater by improving the placebo effect. So it may be that when you tell the patient, I've opened up that narrowing, you've got a stent inside now, the blood supply to your heart is improved, do you feel any better? They are much more likely to say, yes, I breathe better, I've got less chest pain. But also importantly, those pains and niggles that they have that may not have been their heart are easier for them to ignore. And they're more likely to get on the treadmill and exercise and push themselves because they're no longer scared that they have a narrowing in their artery that hasn't been fixed. And overall, improving that placebo effect may improve the overall effect of what we do. We could also improve the true effect of what we do by increasing the efficacy of that treatment. And that might be to select people who have the most to benefit, or to have a better result from our stenting procedure, or exactly what we do with our therapy. In the end, I think the link between stenting a patient and expecting them to feel better is actually very complex. And the reason in our clinics we see some people who feel better and some people who didn't get as much benefit as we expect is not necessarily because the stenting didn't work, but actually because symptoms are complex and affected by a lot more than just fixing one aspect of their disease. We had assumed that when someone comes to us in clinic with chest pain and they have an angiogram that shows a narrowing, we could just stent that narrowing, open up the artery and expect that they will feel better. We see in the cath lab that their blood supply to the heart improves, and we can scan them using tools like the stress echo that I talked to you about and find that the amount of impact of the reduction in blood supply to the heart on their heart function also improves. We had expected that then they'd tell us they felt better, we could record they felt better, and then they'd get on a treadmill and exercise for a lot longer. In ORBITA, we managed to see everything up to the stress echo improvement. We saw these patients, the stents worked, the blood supply to the heart improved, the heart function improved. But we didn't see everything else that we expected to the extent that we expected. And many people said that was because it was a terrible trial or it had certain limitations, and of course every trial has limitations. But in fact, I think the reason ORBITA really differed from the trials that had gone before and from our clinical experience, where many of our patients say they feel better, is that in ORBITA we were unable to tell the patient that we'd fixed their narrowing. And the action of telling them we fixed their narrowing makes us move down the pathway. It makes them ignore chest pains that have perhaps not their heart and start to feel better. It means that we can record they feel better because we're satisfied that we stented them correctly, and they're much more likely to treadmill for longer because of course you don't push yourself as much when you're worried that you may have a narrowing there that hasn't been fixed. So in conclusion, ORBITA really tested how we do trials, and it was the first of its kind in terms of for stenting, and it really proved that trials like this can be done and that they're important for patients. It also showed that it's important to test what we do, because stenting these stable angina patients has become a procedure that we do a lot, has become big business for some companies, and it's important for us to think about whether it works. We did show that stenting was safe and it definitely improved the blood supply to the heart, but in this specific trial with patients with single vessel coronary artery disease, the amount of improvement in their exercise capacity was not as much as we'd expected, and that was a surprise. However, 1 in 5 more patients did say that their pain had gone away. That was not 100%, but it was significantly more patients in the stenting arm than the placebo arm. We also found that the more severe the disease, the more stenting improved the blood supply to the heart. And for many patients that would be important because it may, in the end, show that if you improve the blood supply to the heart, you may reduce the impact of that narrowing on having a heart attack or death in the future. And we're waiting for more trials that are testing this because, of course, ORBITA wasn't designed to test that. And it's also shown us that symptoms are very complex and they're affected by many more factors than just fixing the narrowing we saw. It's also important to put ORBITA into context. So I've said this a few times because I think it is very important for patients. These patients had stable angina. They were not heart attack patients. And heart attack patients are the majority of the patients we stent in the cath labs worldwide. This trial was not designed to look at long-term risk in terms of heart attacks or death. And there's much bigger trials looking at that to try and work out whether stenting some of these patients may have an impact on heart attacks or death in the future. The trial was focused on symptom relief and quality of life, and that's all we were powered to look at with only 200 patients and with our short follow-up time. Now in this trial, the tablet therapy was intense. So actually for many patients, you wouldn't want to take 3 anti-anginals for the rest of your life. And even if I told you that a procedure was exactly equivalent to having the tablets, you might prefer the procedure because you'd like to take that upfront procedure, not to take those tablets forever. And so for many of our patients, a stent might still be preferable if they get given the options. And there may be others who say, you know, I'm happy with my tablets, I'll carry on as I am. So finally, I'd like to thank everyone who's involved, and also very importantly, the Imperial BRC, because in fact this trial, we applied to all of the major funding bodies and found it very, very difficult to get any money, because people thought it was never going to be able, we would never be able to recruit, we would never finish the trial, and it wouldn't be important. And in fact, it's people like Professor Weber who funded the trial and helped us to get this done here and showed that actually internally funded trials can be important and do have an impact on patients. And my final thank you is this bunch of very special people who are some of the patients who formed the ORBITA trial. And it's with patients like this who are up for having a procedure in which they have a 50% chance of a placebo with a potential risk of having tubes put into their arteries, who make trials like this happen and mean that research for patient benefit is something incredibly important and very achievable. And so thank you very much, and I'm happy to take any questions.